I'm just going to present my perspective. So I work at Koklav and Dhirubhai Ambani Hospital. Cost limitations are few. Before that at Columbia, before that at Dana-Farber, before that at Albert Einstein, before that at Sloan. And here I bring the cost implications. So one of the things that we saw, and very nice, my slide is not showing, is that the lung cancer costs are one of the highest costs. And I just had a BMJ presentation wherein the largest cost that we see was in lung cancer targeted therapy. When you really look at all the different targeted therapies in the world for different malignancies, lung cancer targeted therapies cost the maximum. When we talk about driver mutation positive lung cancer, we cover a whole host of driver mutations. And the first thought that should come to a clinician's mind when you see a patient, especially in the clinic, is whether this patient is going to be able to be covered by the first line options that we have. And most of the first line options, as we all know, are extremely expensive. When we talk about osimertinib, alectinib, dabrafenib, trametinib, lorlatinib, any one of these that are being sold in the market, we know are above lakhs of rupees. So can the patient pay? Does the insurance pay? If it's not available in India, do we import? Are there clinical trials? Is there a compassionate access program? And what happens when there's none of the above? So one of these, I was just preparing for this talk, and I went back to data that comes out of 2000, early 2000s, then late 2000, 2015, 2019, 2020. So how does the payer arrange for payment for cancer treatment? And one of the things that I saw again was when you look at lung cancer, the therapy is one of the most expensive treatments. You look at the payer. How much do you need to pay to be able to cover your insurance costs? And the insurance costs for a normal payer, when we don't talk about these esoteric luxury medications, I call them luxury medications mainly because these are so expensive that if I were paying for it, I would think twice. But when you talk about the routine coverage, even the routine coverage is extremely expensive. And out of the circles that we see here and the kind of average claims for different cancers, the highest claim comes in for lung cancer. Today, we have so many options for lung cancer, and that just means that you have to get out there and try to treat. The patient has to get out there and try to cover. The family has to get out there and make arrangements for their loved ones. But how do they do that when the costs are so high? That's where comes in the information that there was 2019 when DPCO slashed prices. And especially when we talk about driver mutation positive lung cancer, the driver mutation that comes out on the top, the driver mutation that is the king is EGFR. And you have several generics, you have several biosimilars now to be able to cover the cost. And after DPCO, the costs have definitely slashed. There is some hope for cost limitations and to cover our patients with these drugs. Is biosimilar the answer? When you look at the development, so one of the things that I was really not aware of, and one of the questions that was asked to me when I was interviewing with TMH from New York, what do you think about biosimilars? And I said, yes, because I couldn't really understand at that time what implication did biosimilars have in India. And fast forward to now, when you need to remember each vial prices of the biosimilars. Why? Because they are relevant. They have really flooded the market. And one of the drugs that I don't have in the trastuzumab bracket is the trastuzumab from Intas, which we all have figured out. And so similarly, now we have several lung cancer drugs available as generics and biosimilars. And really, a clinician has to be savvy enough to figure out all these drugs no matter where you practice, because of what kind of clientele will enter next into the room, where you need to be aware in the interest of the patient as to how to get them the drug. And if it is the generic and the biosimilar, so be it. The idea is to cater the right kind of therapy for your patient. So definitely go to biosimilars. Next to me is clinical trials. A lot of these novel drugs are available as a part of clinical trial. So we have the WhatsApp group. I almost put it there. And then we have the CTRI website and of course, Google. Google Baba is ever friendly, and we can certainly search which trial, which drug available for our patients as a form of clinical trial. But at the same time, the challenges for clinical trials are known. A lot of our patients don't meet the criterias and fall out of inclusion-exclusion criterias of clinical trials. Having said that, when I run these multiple trials and I have space empty, trials not enrolling, my heart breaks because I just can't believe that every patient has the capmatinibs and the selpercatinibs in the world. Every patient has the pembrolizumab and durvalumabs in the world. So we have to step up as clinicians and really look out for clinical trial availability and guide our patients to the right kind of therapy wherever available. Now to touch upon the meat of the matter, which is specific targets. I think all of us are aware of this, and that's why the digression. So we know of the Archer study, we know of the Flora study, we know of the Tata data. I'm sorry, the slide has not come out fine, wherein we look at chemo plus gefitinib. And we have the data today in the interest of cost also, not just the survival. We have to be aware that we have just moved away from single agent first generation TKI, typically, specifically in mind with this data from Tata Memorial Hospital. And we have this second generation with afatinib, where we know that there is a provision to move on to the second line therapy. If at all the patient were to develop resistant mutation in the form of T790M, you keep the third generation for the next line. And we saw the geotag study enhancing survival in this situation, wherein you can really move the second generation up. So what are the finalities for cost saving in the treatment strategies? You know, you could do the first generation first line only for patients who can afford it. But most of us, sorry, third generation first line for the patients who can afford it. But most of us who are not able to do that would then think of first generation plus chemotherapy with the current data, or the second generation if the patient can afford that. And with the current market where you have the generics and the biosimilars, literally this is something that has become very doable, where you could implement a second generation or you could implement a first generation with chemotherapy very easily for your patients, where the patient cannot tolerate and cannot afford a second generation, even cannot tolerate more than a first generation. You would then go ahead and give a first generation. Then it brings me to other cost-centric specific target solutions for adenocarcinoma driver mutation positive. For ALK, crizotinib stands out, ROS1, crizotinib, MET crizotinib, HER2, afatinib, trastuzumab. And for the rest, again, it falls in one bracket. I may have left out a few, where it is chemotherapy, and if the patient has high disease burden, you may think of adding a BEV. But honestly, one has to really look out for alternate solution. And here's a few that I will show you. So this is ALK inhibition response from crizotinib to a patient who couldn't afford the third generation. And then there is progression. And then there is compassionate use of lorlatinib, patients still alive on lorlatinib, 2 years down. And this is on compassionate program. So really reaching out and looking out for what else is available. Is a trial available? Is a biosimilar, or compassionate use of the drug? This is a ROS1. Crizotinib failure, lorlatinib, and the picture is out there for you to see. It's a massive disease in the chest, and all of the disease melted with lorlatinib, and a magical response prevents the patient from intubation. This is a patient on BRAF-MEK inhibition clinical trial. This is not a clinical trial here. Transparency. This is a trial from my previous patient, and significant response from BRAF-MEK inhibition for this patient. Elderly patient, could not do chemotherapy, found out to have BRAF mutation positive, and was offered BRAF-MEK. I had to drop the MEK as a part of the clinical trial, and just on BRAF inhibition, excellent response. Capmatinib for a MET amplified patient, again, elderly patient, couldn't do chemotherapy. On the sequencing was found to be MET amplified, an excellent response to capmatinib in this setting on compassionate access program. So the writing on the wall is we have to know our patients, we have to know our circumstances. The succinct message that I really wish to deliver is we have to understand the patient's pocket, and the rest is all jugaad. And the jugaad includes insurance, it includes biosimilars, generics, clinical trials, compassionate programs, and really you have to get out there to figure it out for your patient. You have to be aware, you have to be savvy, and you have to fold your sleeves and ask, what can you bring for your patient in these settings? So I hope I've kept it short and sweet and delivered the message that I had to. I decided to not bore you with the data. Thank you. And
thank you very much.
Thank you, Mukesh, for having me. This is a very, it's a great meeting that you're doing. Thank you.